Hello everyone, I'm Dr. Lekashvi Amberson and today we are going to have a quick overview on Horner's syndrome. Horner's syndrome is a high-yield clinical finding that tells you something is wrong along the oculosympathetic pathway. It is more than just a triad, it is a red flag sign of something serious. Horner's is defined by the classic triad on the affected side. Meiosis, the pupil is small because the dilated muscle is paralyzed. Ptosis, a droopy upper eyelid due to denervation of the Mueller's muscle. And anhidrosis, loss of sweating. Crucially, the pupillary difference or anisocoria is most obvious in the dark, where the normal pupil dilates but the Horner's pupil fails to. The sunken eye appearance in ophthalmos is usually an illusion caused by the droopy eyelid. Localizing the lesion guides your workup. The key is anhidrosis. Let's look at this three neuron pathway. This is the oculosympathetic pathway, and the first order neuron is located between the hypothalamus and the C8 and T2. And the second order neuron is between the C8 and T2 to the superior cervical ganglion. And the third order neuron is the superior cervical ganglion. So in this pathway, anything after the superior cervical ganglion, any lesion after is a postganglionic lesion, and any lesion before this superior cervical ganglion is preganglionic lesion, and anything between the hypothalamus and the C8 and T2 is a central lesion. If the lesion is central, you get a widespread anhidrosis affecting the face, arm, and trunk. Think of stroke, especially the Wallenbergs. If it's preganglionic, the anhidrosis is limited to the face. The big differential here is a Pancoast tumor in the lung apex. If it's postganglionic, there is little to no anhidrosis because the sweating fibers have separated here. The urgent cause is a painful carotid artery dissection. To confirm your suspicion, we use the aprachloroidin test. This is an alpha agonist. In the denervated honest pupil, the muscle is supersensitive and responds with a dramatic dilation, confirming the sympathetic damage, while the normal pupil barely reacts. Your priority in a new onset honors is ruling out the emergent causes, stroke in case of central lesion, Pancoast tumor, preganglionic, and carotid dissection postganglionic. Remember the triad, use the anhidrosis to localize the lesion and order that urgent imaging and treat accordingly. Now I have a question for you, where a 55-year-old male presents to the clinic with a 3-week history of a left-sided headache, which he describes as a constant severe pain around his eye and temple. He also has noticed his left eyelid is drooping and his left pupil seems smaller than the right. On examination, there is partial ptosis of the left upper eyelid, meiosis of the left pupil, and reduced sweating on the left side of his face. The left pupil's light reflex is intact, but it is slow to dilate in dim light. Which of the following is the most urgent diagnosis to exclude in this patient? It's a task for you guys. Please drop your answers in the comments. Thank you for your attention. Like, share, and subscribe, and follow us for daily insights and updates. See you until the next video.